Cough is one of the most common diseases. Cough is classified according to duration, defined as a cough that lasts less than 3 weeks for acute cough, 3 to 8 weeks for subacute cough, and 8 weeks or more for chronic cough. Most patients present with coughing for days or weeks. These coughs can be caused by a variety of causes, such as acute upper respiratory tract infections, such as colds, are often the cause. Usually is treated within transient hypertensive treatment is most likely to improve. Most of these acute cough patients have symptoms within 3 weeks. However, it is not uncommon for cough patients to have a cough lasting more than 2 months. In clinical practice, these chronic coughs are not easily treated by treatment with acute or subacute cough. Therefore, a different approach to acute or subacute cough is needed for patients with chronic cough. Causes of chronic cough include postnasal drip syndrome, bronchial asthma, smoking, reflux, esophagitis, and ACE inhibitor. Patients with typical symptoms or signs may be able to make a reasonable estimate of underlying disease and appropriate treatment. However, in reality, many patients do not have characteristic features that indicate a specific disease. Thus, there are two approaches to the treatment of these patients. One of them is to perform various tests to find out the cause, to identify the cause, and then to treat it. The other is to try empirical treatment in the order of common causative disease. In reality, it is necessary to find out the cause within the range that can be practiced by the primary medical institution, and to perform the latter method for a chronic cough patient whose cause cannot be found. When performing the latter method, it is important to know the frequency of common causes of chronic cough. The common cause is the frequency of the disease, so you can decide which empirical treatment to try first. The most common cause of chronic cough is the P&D syndrome. P&D syndrome means that the mucus produced in the nose and sinus is coughing naturally or intentionally, feeling high in the pharynx or continuing to throat. Symptoms of accompanied by posture may include rhinorrhea, a habit of removing the sputum of the neck, a feeling of discomfort or dryness in the throat, and a throbbing feeling. In fact, we will examine the cause of chronic cough and discuss the diagnosis and treatment of P&D syndrome. We will analyze the causes of chronic cough and think about effective treatment. From October 2015 to June 2016, we studied patients with chronic cough who visited the outpatient department of otorhinolaryngology. Chronic cough was defined as a cough lasting more than 8 weeks. The criteria for selection of the patients were as follows. First, according to the definition of chronic cough. Second, by normal chest radiography. And third, between 18 and 70 years of age. 90 patients were eligible for selection. Among 90 patients, 32 were male and 58 were female. The mean age of the patients was 44.1 years. The diagnosis of PND syndrome is mainly based on the patient's medical history, physical examination, imaging findings, and response to treatment. The patient was diagnosed as having PND syndrome when he experienced empirical treatment for PND syndrome in patients without any special symptoms and signs. The first case was diagnosed as PND syndrome by medical history and physical examination, and the test to distinguish causative disease causing PND syndrome was performed. Causes that cause postprandial rhinitis include non-allergic rhinitis, allergic rhinitis, and chronic sinusitis. Rhinoscopy, allergy test, and simple sinus radiography were performed for differential diagnosis. For patients with chronic cough who do not have suspected symptoms or signs of specific underlying disease, empiric therapy for PND syndrome was used for 1-2 weeks. Patients with symptomatic improvement were diagnosed with PND syndrome. Patients who did not improve symptoms were referred to a senior hospital for further testing. PND syndrome was diagnosed with baseline disease, and the appropriate therapy was selected according to the etiology of the disease and treated for 2 to 4 weeks. Oral antibiotics and nasal decongestants were given to patients with chronic sinusitis, and oral steroids were used in the absence of symptomatic improvement after 1 week. Treatment of allergic rhinitis was performed by avoiding and medication of causative antigens. Medications include oral antihistamines, topical steroids, and occasionally nasal decongestants. Drug therapy for non-allergic rhinitis has been given with oral antihistamines and nasal decongestants. If symptoms improved after 1 week of administration, the same drugs were used for 4 weeks. In the absence of symptoms after 1 week of administration, additional topical steroids or oral steroids were administered. The cough variability was assessed using the visual analog scale commonly used in clinical practice. The size of the paper was made 10 centimeter and the number from 0 to 10 was written down. The case without cough was set to 0, and the most severe cough that had been experienced so far was assumed to be 10, indicating the degree of subjective coughing. VAS was investigated at the first visit on the outpatient basis, and VAS was investigated 2 weeks after the treatment. The initial cough rate of the patients included in this study was VAS 5 or higher. A total of 90 chronic cough patients were included in this study. The result of 90 patients were as followed: PND syndrome in 64, bronchial asthma in 9, gastroesophageal reflux in 6, chronic bronchitis in 10, and bronchiectasis in 1. 48 patients with PND syndrome were diagnosed in a total of 48 patients who were diagnosed with history and physical examination, and 16 patients with symptomatic improvement after healing after PND syndrome. Of these 64 patients, 16 were allergic rhinitis patients, 23 were non-allergic rhinitis patients, 9 were chronic rhinosinusitis patients, and 16 were patients whose symptoms were unclear after healing. Treatment for PND syndrome was performed first, but 6 patients did not improve symptoms. 2 patients were diagnosed with bronchial asthma, and 4 patients were diagnosed with gastroesophageal reflux disease. The treatment response of patients was evaluated by comparing VAS before and after treatment. The cause of PND syndrome was found in 48 patients, 9 patients with chronic sinusitis. Average of VAS before treatment was 5.67. Average of VAS after treatment was 3.56, and VAS improvement of 8. Before treatment with 16 allergic rhinitis, the average of VAS was 6.19, and the average of VAS after treatment was 3.19, and the VAS was improved in 12 patients. Before the treatment of 23 allergic rhinitis, the average of VAS was 5.87. The average of VAS after treatment was 3.35, and 19 patients showed VAS improvement after treatment. There were no other symptoms or signs other than chronic cough. The mean preoperative VAS was 5.55. The post-operative VAS average was 3.27, and the VAS was improved in 16 patients. The mean pre-treatment VAS score of 64 patients with PND syndrome was 5.84 and 3.08 after treatment. When one-way ANOVA was applied to the mean of the VAS changes in these 4 cases, there was no significant difference between the mean values of the 3 cases of PND syndrome and the experience of PND syndrome. There was no statistically significant difference between the 48 patients who initially diagnosed the cause of PND syndrome and the 22 patients who had prior treatment of empirical treatment and the improvement of VAS by chi-square test. That is the improvement of the VAS of the patients who first performed the empirical treatment was as much as the improvement of the VAS after the treatment of the patients who started the treatment. When I was in clinical practice, I was treated at other hospitals for a considerable period of time. The cause of the chronic cough is various, and there are limitations in the examination to find the cause of the disease. In order to find the cause of the chronic cough, there are various methods such as chest computed tomography, bronchoscopy. This is because a large amount of money is required to perform the branch test, and improvement of the diagnosis rate is not clear even when these tests are performed. Therefore, it is important to prioritize medical history, hearing, and physical examination in consideration of the common cause of chronic cough. First, you should check your history of smoking and whether you are taking ACE inhibitors. The smoker was 10 in this study and had chronic bronchitis due to smoking. In the case of smoking cessation of chronic cough, smoking cessation for about 4 weeks should be observed. Treatment of the ACE inhibitor used as an antihypertensive is also discontinued for about 4 weeks. There is a need for a balance between tests to find the cause of chronic cough and empirical treatment. In clinical practice, however, it is necessary to first try empirical treatment of PND syndrome, which is a common cause of chronic cough. There was no significant difference in treatment outcome between the patients who had undergone empirical treatment for PND syndrome and those who were treated after finding the cause of PND syndrome in patients with unexplained causes. In 22 patients with unexplained causes, VAS was improved in 16 patients when they were treated with PND syndrome, and 39 of 48 patients who were treated after the cause of PND syndrome showed VAS improvement. There was no statistically significant difference between the 2 cases in the chi-square test for VAS improvement. In addition, There was no statistically significant difference in the independent t-test for the degree of VAS improvement in both cases. In other words, when the empirical treatment was compared with the treatment after finding the cause, and treatment effect of empirical treatment was not low. The proportion of patients with PND syndrome was 71.1% among the patients who visit the primary organs of otorhinolaryngology with chronic cough. Both cases were improved when the patients with unexplained causes were treated with empiric treatment for PND syndrome and those with the cause of PND syndrome. This suggests that a chronic cough patient with no special symptoms or signs should give priority to empirical treatment for PND syndrome.